Yeah, if you want to stop sharing so we can go to that help, please.
Well, good afternoon, friends in Malawi. Good morning to everybody here in Edinburgh. Whether you're online or in person, you're really welcome to this Scotland-Malawi Partnership Health Forum. Welcome, Dr. Matambo, fellows, friends, all protocol observed. I'm Stuart Brown, I'm the Interim Chief Executive of the Scotland-Malawi Partnership. Our chair this afternoon, if you're in Malawi, this morning, if you're in Scotland, is Professor Liz Grant, who's the Assistant Principal, Global Health at the University of Edinburgh. I'll hand over to Professor Grant in just a second. Some brief administrative points. The meeting is being recorded. It will go online later today, tomorrow, for anyone to view. And we take your continuing participation in this meeting as your consent for being part of that recording. If taking part online, please would you ensure that you appear under the name which you registered and not the device that you are using. Please feel welcome to introduce yourself in chat. We would actively encourage that. We post the chat log online where messages are sent to everyone, but if you have any direct messaging, you don't record that, so please take a note of that yourself if you'd like to. To everybody taking part online, we'd ask you to remain muted until invited to speak by the chair during the Q&A sessions. If you would then please unmute yourself. If possible, we'd also invite you, by speaking, to switch your video on so that our AV system can pick you up as well. You're very welcome to live tweet during the meeting, and the social media handles were shown on the screen in the waiting room. We'll email everybody a 2-minute survey after this event, asking for your feedback. We completely empathise with anybody that has survey fatigue. Anytime you buy a loaf of bread, you're asked how that's gone for you. But it is important to us in that we learn and improve what we offer, and it's also a requirement for our donor reporting to the Scottish Government, to whom we're grateful for their funding. So we'd be grateful for your time within that survey. We're aiming to end the formal meeting at 12:30 UK time, 1:30 Malawi time, and in the meantime, I'll pass over to our chair, Professor Grant.
Thank you so much. And Dr. Matambo, and visiting fellows, colleagues and friends in Malawi, and colleagues and friends here and those online, it's wonderful to be together and to think today about some of those big issues around global health partnerships and the way we work. But I really do want to extend a very warm welcome to each of you who are in Edinburgh for this special occasion. You know, I first visited Malawi in 1984. I went to the Musa Stadium because for the celebration of 20 years of independence on the 6th of July. That was an extraordinary time. You think so much has changed since then, but one of the really powerful messages that have come through for all those years is that together, Malawi and Scotland, that friendship actually makes such a difference. So much of global health is really about health being global and local health. Our health here in Scotland, your health in Malawi, changing the way that we understand the health of the world. So today, a lot of our talks are going to be around safety issues. Because we're soon going to hear from Sarah Davies talking about safety in medical donations. And then we're going to speak about antimicrobial resistance. And I'm sure you're familiar, but when we think about global risks, and the World Economic Forum has listed some of the big global risks for the next 10 years. Global risks of biodiversity loss, of climate change, of cost of living crisis, of cybersecurity, of conflict, AMR, antimicrobial resistance. cuts through each of us, sits in each of us, and we need to understand how significant diseases and what all of us working in the health sphere and working in all the spheres of interest do. So it is such an important meeting this morning for everyone. I want to just emphasise again, as Stuart has, if you have questions, put them in to the chat. And then after we've had the various talks, we'll call on you and either to speak a question or respond to the question on the chat. But feel free to keep connected because, again, we're connected through conversations. That's what really makes a difference. So we're very keen to hear ideas and thoughts, questions, queries that you may have. So with that, let's turn to the agenda today. And can I introduce Dr. Sarah Davies? I've known Sarah for many, many years. So here you are, Sarah. Sarah is a consultant, a public health consultant working in Scottish Government. And Sarah, you're going to speak on the Scottish Government's recently launched 10-step guide on making donations of medical equipment to low and middle income resourced countries. This is an important area, as you say. This isn't about safety, it's about partnership, it's about making decisions of starting and stopping, it's about equity. So Sarah, over to you. Thank you so much for today.
Thank you very much indeed for the invitation. I've got to remember to look at the hour as opposed to my slides. So if we can put up the slides, if that's possible. But thank you very much. What I want to do in the next few minutes is to say why we did the work, what work we did, how we what happened was that somebody, working with Scottish Government enabling medical devices and bid on federal citizenship. A few years ago, somebody wrote to the Chief Medical Officer and said, what are you going to do after COVID with all the equipment that might be left over? And the Chief Medical Officer said, that's a very good question. Can you have a short life working group to give us some recommendation? So David Cunningham, who's the chair of HITSA, set up a short life working group and asked the Secretary. And it was to look at the safe donation of the biomedical. What we did was then look at what kind of research we should do to set up some kind of documentation. The first thing on that slide, though, is I have to give huge congratulations and respect to the Scottish Malawi partnership. The 10 steps, which was developed well, I think it was published in 2014, but been developed before, actually gives a very good checklist. Our work is in a very much smaller, narrow area of biomedical equipment, trying to find out. But a lot of the principles which were on work with Scottish Malawi partnership, we were delighted to be involved in the work. The first thing we did, of course, as you would always do in a short life working group, is do a literature. And within that literature review, we found a classic case that everybody says that the World Health Organization says 70% of donations of biomedical is not used. We also know the corollary that is biomedical equipment, and I work in medical devices, so you could say I'm a bit biased, but medical devices as opposed to drugs are actually important for diagnosis and treatment, but doesn't get the same visibility. But biomedical equipment from a syringe to a scanner are hugely important, and there are disparities around the world, as our chair has just said about Connect. So we did the literature review. This is a picture that we got commissioned from the Tropical Health and Education Trust to use. And I think again it's emphasised in Scottish Malawi Partnership 10-point checklist. What you see is the acquisition cost of equipment. Underneath it, there's a lot of other costs. So as your own checklist says, put all the costs together and then divide it, because otherwise you will think the cost is what actually is only about 10%, because import duties, transport duties, training duties, disposal of equipment add to the cost hugely. This is something, again, from the literature and from talking to people. There are different ways that biomedical donation can start. And of course, it wouldn't be if somebody has equipment that is no longer needed in that department, or if somebody makes a request. On the first issue, in the report will be published, the CMO's report, the 10 core principles for WHO donation. And one of those principles is that there's no two standards of quality. So it says there is not wanted in places going to be used, but you've got to be careful what you mean by wanted. If it is not to be used in country, it should not be transferred to any other country. So I think that's quite a critical point. And the personal contact, again, echoing what our chair said, I think what we found as ever, partnerships in the past are kind of key in this one. So this is just some pictures from the people who are helping us with literally. They're called equipment graveyards. My point of putting it up is that there is within that equipment both rare earth materials. There's also a possibility of toxic elements within those, and these are just being dumped. And that is not right for any situation. So we did the literature review, it found some good information. We then did surveys, both of the recipients of donors and also people donating. And the next couple of slides just give you some quotes about that type of what we found from the patients. So that there is the issue of spare parts and equipment that goes along with the donations. And I think particularly the second bubble there, it's about warranties and maintenance manuals. These are areas that even when we talk to colleagues who are used to donating, sometimes forget need to be included in the schedule. So after the literature review and the surveys, we developed 10 steps because the recommendations from the CMO's report, I was absolutely delighted with how I was helping to write the form. We only have 3 recommendations. First recommendation is there is no need for guidance. There's loads of guidance out there. It happens to be in 155-page documents or 85 documents or spread around, difficult to get hold of. So the second recommendation was a simple checklist might be helpful. So after we devised the 10-step guide, we then had a few focus groups, and again, Scottish Malawi Partnership took part in focus groups to just check it. And these were the 2 things that came out mainly from that. One was about partnership. The first step is there a need? And we just can't emphasize that enough. It's not that you've got excess equipment somewhere and that you want to send it. Is there a need? And the second one that came out of the focus group was permission to stop a donation. A lot of the time we get sort of in a situation where a donation is wanted or there is a possibility, but the whole process has not been thought through and there needs to be permission to stop a donation. So after all that, this is the 10 steps. It's a very simple thing. On the website, there is the report, which is quite short, and this is the 10 steps, and there's a poster and also something else, which I'll talk about in a minute. We devised it initially as a kind of linear 10 steps, but when we thought about it afterwards, we're not saying it's necessarily linear. The first step is actually critical. Is there a need that's being expressed? We do suggest that the whole 10 steps is read before you start a donation with your partners, because different steps mean different things. We also have steps 3, 5, and 6, which is where we say stop, reflect, maybe don't do it. And again, the Scottish Malawi Partnership also says, are there other ways of doing it? They give a very good example of fixing equipment rather than sending it. But there are other ways of doing it. So those ones in particular. Step 7, I really like because it looks like a washing up bowl to me. And it's about the end of life of equipment. Single-use equipment, I mean, useful equipment, maybe you can wash, but maybe there's a lot of equipment can't reuse, and you are not in a position, or you could not be in a position of sending waste to another person's country. And the disposal was something that's quite critical, and people haven't talked about. The manuals of installation and maintenance of equipment over the next 2 years, as your ministry signed up for it, is it actually going to happen or something else? And then the customs duties. And there was, again, I thought very relevant our partnership checklist. It said people think because it's a charity, it will get through customs. Customs in every country has laws. Whether you're a charity or not makes no difference in some situations. That has to be factored in. So these were just some of the, oops, there's a problem. And then the other thing that's on the website is a checklist, because those 10 steps are a little bit wordy. And we thought having a checklist, and I think there may be something back along with the leaflet about it. It's just an A4 thing so that both parties can have a look and have a think through where you are with all types of steps. So my last slide, I'm sorry if I've taken too long, is really just to say 10 steps additive to your work, but it is about biomedical, which is going to increase in necessity. We always say there's about 20,000 drugs that are used around Europe. There's 500,000 medical devices. Biomedical equipment is going to get bigger and bigger in people's needs, but we need to do it better. And also that there is a way of saying no, a donation is not the right way. So it was really just to say, this is what we've done, there is the information there, and we'd be delighted to take questions later. Thank you.
Sarah, thank you so much. That was very, very clear and exactly what we need to hear, because there's so often assumptions that, oh well, this is the right thing to do, but you challenged us to think about the cost of giving and the cost of receiving. You challenged us to think about that there's no double standards or two standards of quality. There's a standard of quality. So everything that is given has to be asked for, there has to be a need for it. And need to have that permission to stop processes. Not stop giving, because there's different ways to give, different ways to receive, but sometimes the processes of what we're doing need to be changed. We'll hold the questions until 12 o'clock because we'll go on to the next tranche of the agenda. But I really just want to say thank you and to encourage everyone to look at the website and to check out the checklist, because this is essential, this is what we can work with. So what we're going to do now is to hear from two colleagues of mine from Edinburgh Infectious Diseases and Edinburgh AMR Forum, and just a little piece of information. The Edinburgh AMR Forum is probably becoming one of the international for understanding antimicrobial resistance. It's led, the Edinburgh Infectious Diseases and Edinburgh AMR Forum are led by Dr. Adrian Mwangi and Till Bachman. And both of you are the directors for the Fleming Fund Fellowship, which you are here. So I'm going to hand over to Till and to Adrian just to give us a short 10-minute introduction. That's okay. Thank you.
Thank you so much, Liz.
Here we are. Yeah, Adrian. Thank you.
I can start, but just double check your presentation first, but if you begin that one. So forgive us for this hiccup of slide order. It was also well. Okay, I can. Right.
So what we're doing is just finding the right slide.
Okay. Yeah, why don't you start a seat? Yeah.
Good morning, everyone. I am Adrian Mwangi. Fellowships for Kenny and a bit of context why I'm involved. we know that AMR is global efforts led by WHO, but have global strategy for control of AMR, and underlying have national action plans. And these national action plans for the basic requirements provide resources for add support for improving infrastructure as well as capacity, and as part of any right. And basically within the training plan, we're given a mandate to provide a comprehensive capacity. Capacity package tailored to the fellows, needs of the fellows, and the needs of the institution where they are nominated from, so that they can support the national mission.
I think you just need to speak a little louder in the aisle.
I do have a microphone, but it's just a little bit more. I think it's fine.
Shout, Adrian. The oil is looking for you.
So I hope you can hear me now. Yes. So we're given a 5-year capacity package tailored to the fellows and needs of the segment where they are in the segment so that the fellows they can support the implementation and the evaluation. By the end of this year, we'll have delivered 90 fellowships. Uganda having 12, Malawi 6, and Kenya we have 2 policy fellows. These are nominated from the ministries of health, agriculture, and environment, and party academia. And they are nominated to fill 3 themes: diagnostics, surveillance, and AMR stewardship. And basically what we do is provide training to support the national. And here they get training tailored to them. When they come here, they deliver a handle mind. They also deliver a collaborative project, because this is a One Health framework we need to work to deliver this work. So the fellows have to work across all these sectors to deliver this collaborative project. And then they deliver a policy brief for their line ministries. They then work together with the cohorts. Uganda had 2 cohorts, the professional fellowships and the policy fellowships, who then work together to update the national action. But also by doing all this, provide some context on how to design and implement a One Health service. So in Uganda, they have designed their own surveillance plan. It's looking at what is happening in the community and what is happening in the hospital to see how the One Health surveillance plan can be delivered. In Malawi, they have used community reading structure to try and understand how the structure that is achieved in the country can be used to understand and as I say that, speak on behalf of a large group of delivering the classification.
Thank you, Adrian. So, more slides?
Can you try?
In,
The one kind of all right. Yes, okay. Okay, so we had that introduction already. So my name is Stefan. I'm the AMR strategy lead for Edinburgh infectious disease, and I'm now coming in the second phase together with Adrian Wong to co-lead the second phase of the planning fund. So for me, it's a huge opportunity. It really stands for the aspects of AMR. As it was said, as Adrian said, the WHO and other organizations currently advise strategies. So we have the global action plan, we have national action plans, but we have also global AMR strategies. And WHO is presenting this week on the 22nd. So if you're around online, I can recommend have a look. So there will be a presentation of the AMR objectives for the future from the human AMR perspective. And a week later, on the 28th, there will be a presentation of the quadripartite strategy priorities. And what we do here with this capacity building program fits very neatly into these strategies. And for me, again, this is a sign of what needs to be done, or it is an embodiment of what needs to be done with regards to AMR. AMR doesn't respect borders, it's a global problem. AMR is a One Health problem, so human, animal, environment, plants, everything needs to be considered. And also AMR requires partnership and collaboration. I mean, this is a prime example of what we have today. While many years for the Malawi partnership, we need to learn from each other, we collaborate, this collaboration finds solution. So so actually what is really fantastic is that we are increasing almost more than doubling, doubling, yes, as doubling, but there may be more fellows coming into the program. And the presentations which we will have in a minute are showing a testament to what can be achieved with this fellowship. If you move, I think we have one more slide about the key strategic areas of the planning fund have slightly expanded. And for the second phase, the slide, and it really shows the breadth of activities which the planning fund is in the fellowship scheme. And what it also means is that we are looking for collaborations. We are always interested in collaborations. And if you are interested in the fellowship scheme, please come and talk to us either online or today in the network session. I think that I'm going to back to you.
Thank you so much. Thank you. And you might be wondering, why is it called the Fleming Fellowship? Well, you might, or you may know, because of course it's Alexander Fleming. And Fleming was a Scot, born in Ayrshire, I think, but studied in London. The person who discovered penicillin, and he received his Nobel, or when he was given a Nobel lecture in 1945, did say that resistance is inevitable, but we can do something about it. But did we? I think this is one of the things now is what do we do? How do we respond? So it's wonderful to have each of you as Fleming Fellows, but also Dr. Collins, it is a real honour to have you here with us. You're Deputy Head of Research at the Ministry of Health of Malawi. We really appreciate your spending time with us, your insights, and to think together how we do research together, how we bring research into action, how we work with partners, with local partners, with communities that you work with, that we work with, how do we work together to be responsive? So can I hand over to you, and we're going to hear 3 presentations, I think that's right, from Ron Chidamanga, from Harry Galala, and from Catherine Lamana. So for each of you, thanks very much. Would you like the microphone? Yeah, let me bring that forward. And then after you've all spoken, we will have a time for questions. If there are any questions coming in the chat, please feel free, with all of you online, to keep putting questions in, or thoughts, insights, and then around about 12 o'clock to 12:30, we'll have a time to discuss.
Thank you, all for I've come with my colleagues from Malawi and say that what is the national AMR coordinator and also the research. So for us, it was just a quick presentation on just highlighting what the fellows have been doing, and then in the end, I'm going to summarize the benefit that we found and how it's today. So the first one, the presentation is comes coming from the human sector, then followed by current for the laboratory, and then upgrade from the so thank you.
Thank you all very much for hosting us here today. I think I reflect everyone's sentiments that we are really happy and delighted and honored as well to present to you today. I am an AMR surveillance fellow for human health, and an experience that has been almost life-changing for me. In the Ministry of Health, I work as an AMR research associate at the National AMR Coordinating Unit. And what I'll do in the next few minutes is to highlight to you all the burden that we have by AMR, that is caused by AMR, and sort of touch base as well on how we're using our drugs. So the first thing is just to outline some of the things I'll talk about, which is to highlight the baseline infrastructure and also some of the AMR findings, how we're using our drugs, and how the two, the problem as well as the way we're using our drugs, how they relate, and sort of summarize this in a last one. So just to touch base on a little bit of where we're coming from. Currently, we have a working national action plan. We also have a coordinating unit that is implementing the work that is heavily needed. And this is in a One Health. We also have, because the national action plan as well as the global action plan emphasizes the surveillance of the problem of drug-resistant infections. We have a working surveillance system that is feeding as well into the national structures from some private hospitals and public hospitals that are feeding to the national structures, as well as finally, we as a country also share our data with the WHO Plus platform for regional sharing so that we can compare between different countries. However, that being said, when the Ministry of Health did a mapping of our infrastructure, for example, the labs that are providing various diagnostic services, we see that 1,026 laboratories were highlighted to be providing some level of diagnostic services. But when we look at bacterial infections, this number comes down to 27 that were highlighted to be providing a standard or to be providing that level of diagnosis. And upon further scrutiny, after the Fleming Fund had come into place to further analyze this, we find that only 15 were able to provide full results for example, susceptibility panels. So as of right now, this is where we are. And I will talk about the baseline on these 15 laboratories in terms of a retrospective data analysis and sort of looking at what type of data these laboratories produced in the years 2016 to 2018. So the main problem is from 2016, 2017, 2018 is highlighted in the slide right here. And what you note is that we generally have high levels of resistance for one bacteria that is gonorrhea, Neisseria gonorrhea, which has 97, and it also recurred in 2017 as well, something that came up. So that is the second one in the tree. Other bacterial pathogens have been also noted, and these are also glass pathogens emphasized by the World Health Organization, like Salmonella typhi, which had 98% in 2018. And when you look at another private pathogen like Pseudomonas, which causes a lot of hospital-acquired infections, we see that 100% of those pathogens during this sort of quick analysis provided about 100%. And this really outlined to us a baseline which we are working on. And this is where we started. We noticed that some of our drugs, so phenycones, tetracyclines, as outlined on that slide, there are several drugs that are currently in use that were noted to not be effective. And this is something, this was the first big bang that we noticed. And this is the first paper that really told us that we actually have a problem now. And then just briefly, I also touched base on the animal health sector because this was mostly human health. And you will see that in Malawi, we have 3 laboratories that are catering for all animals in Malawi in terms of bacteriology services. And this is obviously something that I don't have to outline that is a problem because the northern region has got 1 lab that we say is providing standard care in the services, and that is obviously an issue. So looking at the 4 priority passages that are outlined, and this is another mapping exercise that we did with the Fleming Fund as well. And we see that some of the pathogens that have been outlined are E. coli, which provide about 60% of our data. And I'll just quickly look at E. coli, not to take too much time. And we see that for poultry, okay, which is a species that as Malawians we truly rely on in terms of our protein production. So poultry, you can see that there is high rates of resistance in ampicillin drugs, cipro, and sulfamethoxam. And this is like we had about this is E. coli accounting for about 60% of our isolates, and in total in this mapping we have about 700 isolates. So this is something that is worrisome when we see, and you can see these rates of resistance are cutting across on all regions. Of course, I can say that this data, first of all, is preliminary data that we looked at, and it has given us the first picture that we gave us the first picture that we need to highlight to focus on our surveillance approach. How about the way we're using our drugs? And I just want to outline a report that has just been published by the Mapping Antimicrobial Use and Antimicrobial Resistance Partnership, which is also a Fleming funded initiative, which really looked at the same 3 years, 2016, 2017, and 2018, to find out how well we're using our drugs. And what is something that to highlight right now is that over 90% of our use is on only 5 drugs, which are in the access category. So we are relying on 5 drugs, and that is obviously something that is a problem because we're putting immense pressure with 5 drugs as outlined. And these come from the access category. And this is something that we really need to work on and diversify and give as well. It also alludes to the fact that our patients who certainly need other drugs are not being given the drugs they need. And it outlines that we need to diversify and improve the strategy on this in this. And then just to as well just outline really how it looks for the 3 years. You can still see that the first 5 drugs are taking almost really are taking. I think it's consistent for all the 3 years. So we have more than about 60% all the way to 90% on all the drugs. So I'll just leave this for a second for you all to just appreciate. So a quick analysis of how we are using our drugs and as well as how this relates to the AMR burden. You can see a sort of a moderate positive correlation between the amount of drugs that we're using and the resistance that we're seeing. So the more we're consuming our drugs, and you have to remember that we are using only 5 drugs for about 90 or more than 90%. And it sort of looks like the more we're using and keeping pressure on these 5 drugs, the more resistance rates that we'll see. And this is something that we are worried about and definitely needs some sort of intervention. Which is why Malawi decided to monitor our drug-resistant infection, and basically we want to highlight and inform national strategies. We also want to monitor this trend and improve patient outcomes. And say personally as a doctor as well, I noticed really that there are not too many epidemiologically trained people who are interested in data, so not too many who are interested to make a difference in terms of drug resistant infections, because the burden is people are sick and a lot of people go into that space to assist, and that is also okay. However, Malawi is moving from and has actually moved from a place where we have limited data that we need to work on, and people need to put emphasis on this data to make action. And it's also complex because we're also looking at human health and animal health, and also we need to strengthen the environmental health sector contribution. Therefore, the Fleming Fund Fellowship really did offer me personally an opportunity to sort of emphasize on how better our ministry can use this data by operating several skills in me, as well as my colleague who is also from the animal sector. And I think this was a great opportunity for us to learn and come back so this is what okay, so I guess in summary though, the problem we have within the data that shows that we know that the way we're using our drugs is putting pressure and driving the problem. And the fellowship in the AMR surveillance has been really a pivotal investment that has been given to Malawi really to improve on these two things. So as we move forward, I would say that we need to incorporate the environmental sector's contribution to this problem and also better work on the solution. Thank you very much.
Thank you very much, Ron. My name is Harry. I have many collaboration thank you. In the third, health AMR approach. So this morning, I'm presenting on insights we should give you health and affairs. One, why very glad to answer this question. Highlighting that after very resistant, so the fact that one that means is a common problem that is affecting all the sectors. Normally, we have a common problem, and there's always need to form an arrangement in order to defeat that problem. So, I'll be taking insight on a contribution. Yeah, I'm not going to go much on this slide because it's highlighting the outcomes of the fellowship which have already been presented. Yeah, so this is one of the activities that we've done with this a relationship building between human health and animal health. So one of them was joint education or trainings, and these trainings were provided by the University of Edinburgh. And mostly the trainings are being provided to the whole audience of the fellows, or sometimes they will be provided according to the fellow category. So you can see that the trainings such as epidemiology of resistance, the significance of AMR, data analysis, and so on and so forth. Such type of trainings were being presented or being delivered to the whole audience of the fellows. But there are also other types of trainings that were tailored according to the fellows. For example, things to do with the diagnostics, early management system, where particularly being presented the human health and animal health fellows. We can also see probably use and surveillance and policy. Stable training is also being tailored and presented to those with surveillance of mind health and so this entire of providing the trainings and hence the spirit in us tells that everyone is the one with the problem and therefore has to be fought using joint efforts. The second approach that assisted us to build a relationship between particularly human health and animal health was mutual assistance. That was done at low level. So there were a number of things that human health and animal health were doing together. One of them was the skills transfer. So I have to emphasize here that in Malawi, animal health was a bit lagging in terms of progress as far as and human health was a bit late. So the time when we go to human health and we train them in some of the another activity that was happening was experience sharing. For example, human health would be good at what system. So we share our experience with animal health and animal health sometimes we also share our experiences with us. Then we at lab level also doing complementary testing. This is whereby we do diagnosis, maybe not fully in human health. Then we get such isolates and send them to animal health, and they can also do diagnosis. So doing, we were assisting each other as far as quality diagnosis is concerned. There were also times when we share agents and consumables, but there were also times when we also do what we call proficiency testing. So this type of mutual assistance occurs apart from the relationship between human health and animal health. Another important activity that enhanced a relationship between students was the collaborative project. So as fellows, we engaged in the collaborative project, and this was the hub that mostly brought all of us together, and we will be able to learn from each other in this collaborative project. So I have to mention that in this project, each and every fellow had their roles, but at the end of the day, all these roles meshed together to answer the question that we had. So I would say maybe 60 to 70% of the times that we felt met, we need to talk about the collaborative process. It's the one that helped each and every sector to learn more about that. Yes. So basically, these are the three main things that we rehearsed a partnership between these two sectors. Despite having all those success stories, we also have to mention that during the fellowship we had problems. One of the main problems, one of the main challenges was COVID-19. So if you remember, COVID began around 2020 to somewhere 2022, and the fellowship was also running during the same time. So it really affected a lot of activities related to the fellowship. So for instance, there was no, at some point, no in-country database, and this affected us to meet and discuss matters. There were also travel restrictions. This meant that our mentors couldn't come from here, Edinburgh. It doesn't allow you to many of trainers to do some things. But also, we couldn't travel from Malawi from here to get trained or attend some conferences. Another effect that came with COVID-19 was our present healthcare system in Malawi. And this resulted into having all the attention of COVID-19 other than focusing on activities to do with fellowship. But also, as you can see, most of us professionals, another challenge that came with that is that we had our competing priorities. So instead of focusing on project, it would be next time. However, there are a number of things which we constructed. One of them is fairly collaborative projects which we took. And this project has acted as a blueprint for one youth surveillance. I have to emphasize that this is the one of the kind that I came about. Another success is that there have been improved communication between human health. And there's also been networking, networking that is local. We have formed a lot of networks locally, that is in Malawi. Also, we have a lot of networks. We have colleagues from Kenya, we have colleagues from Ghana, also we have colleagues from inside of Scotland. Another success is that we are the first cohort with international standard knowledge, which we've been able to apply for. Finally, another success is that we have been affiliated with the University of Edinburgh, which we all know is a prestigious national renowned university. Yeah, this whole journey has given us a lot of lessons. One of the lessons is that we have learned that it is possible to build a human and animal health partnership. So we have come to learn that the use of antibiotics in animal health is as significant as human health. And initially, we didn't have such a we have also learned how to set up a operating project from the project side. We have also learned different approaches, diagnostics as observed and space. So there could be times when we go to an lab and then new techniques of diagnosing. Finally, we also appreciate that it is possible to optimize the use of antibiotics. In giving so
good morning, Kathy Kamana. And so my responsibility this morning is to talk about the World Health collaborative project. So our One Health collaborative project aimed at characterizing the resistant patterns of AMR and its drivers of E. coli from poultry, humans, environment as a central region of the land. And it was One Health, so all the fellows like human fellows and animal health fellows did work together. So this project, as we have already said, the project is really done because of the burden that we have in AMR, and this in Malawi is not exceptional. For the burden is that it is all in the world. So the collaborative project, the aim was to see the AMR patterns in humans and the human, poultry, and environment against the 9 classes of antibiotics and the drivers. So for the drivers, we had a qualitative study that was done on knowledge, attitude, and practices of the people towards the antibiotics. The study location was in the region, which had 9 districts, and it had a pyramid structure. So the pyramid structure has a background of its own. It is not just a pyramid that we just should do, but it's something that has a background. In animal health, in 1960, the government of Malawi introduced the black oat crop in Malawi, and this was the aim of the black oat crop was to crossbreed with the local chickens for them to have the high yielding meat and egg production. So the government set up farms in the central, northern, and southern region. And these farms acted as nutrients for for the production of chickens. So our study focused that one of the nuclear farms of the government, that is the farm that is in the central region, since the project took place in the central region of Malawi. These multipliers, this nucleus is at the top. So it is producing the black hole top that is to be distributed to the local farmers for their for the improvement of their local grids. So it is subsidized, it is meant for the local farmer. Now in between we have multipliers that take the seed or take the chicken or the seed from the Wimba farm, which is the nucleus, the government farm. They multiply it and keep on giving it to the farmers for it to go all over the country. And the smallholder is the end person who gets the chicken and then use it either way, whether to sell or to eat. So that's the last phase of our study. So we had samples that were collected from the nucleus, the multipliers, and the smallholder. In total, we had samples that amounted to 1,808, and then those are the distribution. From the chicken, we had broader swabs, and from human people samples, and from the environment, we took the water sample. And I'll share with you the preliminary results of the study. So we're still analyzing our data and we're still coming up with because our data is rich, so we're still coming up with the results. So I'll share with you the preliminary results, just a brief of them, but we'll have more as time goes as we work on our data. So from the knowledge, attitude, and practice, these are the findings that we from the knowledge. This is what we got from our data. We got that 58% when we asked about knowledge on the antibiotics. The farmers did not, 58% of the farmers knew what antibiotics were. And the blue lines are showing us the results from the 58%, where the nucleus got the highest mark, like it got almost 100% of the people in the nucleus or the population were included within the nucleus knew what antibiotics were. And then the lowest figures are from the smallholders. The smallholders have little knowledge on antibiotics. And for AMR, they knew what AMR was. The 53% knew what AMR was, and the brown or yellow, orange color shows us the results. So in 53%, the multiplier shows to have a higher percentage of knowledge in antimicrobial resistance, followed by the nucleus and then the smallholder. In this study, their attitude towards the AMR, if it is a problem to food animals or if it is a problem to humans, these people at the nucleus and multiplier agree that it is a problem for both food animals and human. But in smallholder, there's a small percentage of the people that do not really agree, or they do not know. They are just at a basic place. And so it's a 16% that do not know that it is a problem for food or human. And if the time they were asked if they know that it is important. So LMR to them, about 33% of the nucleus now shows that 33% shows that they don't really go with the idea that it is important. But and there is the lowest figure being 29% that is smallholder and the smallholder farm. In their practice, they were also asked if they do medication. This is both in human and animal. So in a human setup, if there is a safe medication, if they just go to the shop and get drugs and drink. So 56% of the people say they get prescription. And out of those 56 people that get prescription, 75% of the people say that they finish the prescription when they finish the prescription. And that small percentage of 12 say they stop drinking antibiotics when they feel better. While in animal, 62% they also get prescription from the vet, and they finish the drug as it is prescribed. But the smallest percent of the claim showed that they also withdraw when they are fine. We took the samples to the laboratory, and after the analysis in the lab, the 9 classes of antibiotics, it was realized that the ampicillin, which is the first corner, showed that it had resistance in all the 3, the environment, animal, and human. And also, poultry showed the resistance. So this is just one of the analysis from the laboratory. This is in our pyramid now, the resistance percentage in our pyramid, showing the environment, human, and the chicken. So the ampicillin is the one that is at the beginning, and the cotrim is the one that is at the end. But this one is also, it has some interest in the middle where we have the nucleus, where most of the drugs show resistance. So in the nucleus, we have a lot of resistance in the environment. This study that has been done is like a baseline study, and the information that we have, we want to take it to the policy brief, and we have now the evidence. So the evidence-based awareness campaigns are going to be drawn out of this, and also it works as an opportunity for further studies. We have more people coming into the fellowship. We have other researchers that are around. They can use the same graphs that we have in our projects to go on with the studies, so that we have the basis, we have the evidence of what is all about AMR in our. So that's what we basically have done and what we are doing. Thank you.
My colleagues have really set the background of the significance of the 25 fellowship, and my role is just to sum up in terms of the impact now in national day. So we know that as Malawi is one of the countries was part of the 25 fellowship, and for us, what we were aiming at was not just building a patient capacity. Or just strengthening capacity at an individual level, but also wanted to aim at a country level. So the impact which this fellowship has done is not just at 2, 3, or 4 individuals, but has multiplied and benefited the whole country. So you can see that from the presentation which has been done, the fellows were trying to reach out to the 4 main areas. So for Malawi, we have a national plan for the stewardship, and sorry for the small font, and then unfortunately I can also see from the laptop. So you can see that from the 4 main thematic areas, what we have there is that the first one on top is education and awareness. That's what the basic thematic area. The other one is surveillance and research, and then optimizing the use of antibiotic and investment and sustainability. So what we did as this fellowship, we are trying as much as possible that the fellows should try to reach out to all those 4 thematic areas. So from the presentation which the fellows have done, the contribution made to those thematic areas, that the overarching one is that we have tried to make sure that we are investing into microbial stewardship and also sustainability in terms of the national action plan. So the selection of the fellows, we we involved government employees because of the issue of sustainability. So you find that we selected colleagues from the agriculture and so that they should be able to train and also impact knowledge to their colleagues. And we especially emphasize on issues of surveillance in this fellowship, so that we should enhance the competences in terms of evaluating the impact of antimicrobial resistance, and if you also improve the system, the surveillance system. That's why we have fellows working at the Public Health Institute of Malawi, which is a national body which is involved in the issues of surveillance, and if you quite get the approach, and if you talk about international integration through the cross-border. For the laboratory, that was also an aim for us. Also, human capacity to generate the quality also involves the issue of antimicrobial use, which was also one of the areas which one of the fellows also contacted, and we are planning to share the framework data. In terms of involvement of the fellows at the national level, what we are looking at is that when we started issues of antimicrobial stewardship, we did have a lot of information on the ground, and we did have a lot of documentation on the ground. So we invested, yes, in terms of infrastructure, invested in terms of issues of governance, and even come up with guidelines. But what is also very key is one of the outputs of the fellowship scheme is involving of the fellows in coming up with the guideline, the Malawi surveillance guideline. This is one of the outputs which the fellows have really spent their energy and working. And what we have is also the National Standard Treatment Guideline. This is like our Bible for prescription. We had the first standard guideline, and by the time where we had that kind of standard treatment guideline, along the way we understand that some of the advantages are not effective. So the fellows utilize this data through the WHO aware participation and the AMR trends also to feed information to the national standard guidelines. And I'm happy to inform you that we are going to launch the revised treatment guideline this year. The other area which the fellows have been involved is revision of the National Action Plan. Because the previous one in 2022, and we have got the revised version. Our work was made easy because we had fellows who were able to generate the data. We had fellows who were able to know the trends of antimicrobial resistance. We had fellows who were able to understand what is happening to what they approach, both the sector from the agriculture and also from the human health. So you can see that some of the fellows now that picture was taken when we are doing the revision of the National Action Plan. So the members from the National Technical Working Group on antimicrobial stewardship. And some of the slides which have been presented today, let's appreciate what is happening in terms of antimicrobial resistance. And I should also mention that through that we are also having an impact in terms of prescription and even informing the pharmacy ministry of the national body in terms of regulation of use of antibiotics in Malawi. And we had some fellows who also having the task force which was developing some of the standard operating procedures in terms of antimicrobial use. So in summary, most things have already been presented by the fellows themselves. But as Malawi, we are one of the countries which we are happy that we have really benefited from this fellowship program, whereby we have capacitated the fellows on how to come up with this data. Because if you came 5-6 years ago, we didn't have that data, but we have got the data now, and we are now trying to put use of the data, not just at one facility, but at all facilities. And what we are also happy that we have really tapped their knowledge to come up with national document, the National Action Plan. We talk about the guidelines on antimicrobial use and surveillance, and even about training of the antimicrobial strategy committees at the facility. And we're also happy that this is very sustainable because the fellows, they have got permanent position within the government, and the government is committed because they've got a dedicated budget for antimicrobial resistance in Malawi. So we believe that it's not just a project per se for us, it's a capacity building to be there for forever. Moving forward, we know that we cannot reach out to 80 million people. We are not ready for the 80 million people, but I hope that in future we're going to increase the number of fellows. And my colleague already mentioned about the inclusion of the volunteer fellowship, so that we also be reaching out to the animal, human, and even the environmental sector. All in all, as Antimicrobial Resistance Community Center for Malawi, we really appreciate for this fellowship program, and we know that this data has been presented by fellow from Malawi, but should also recognize the mentors from the Western who really spend time in the partner for the coming up with this good work as we have really appreciated. And hope that we are going to continue making a fruitful partnership. Thank you very much.
Thank you so much. What a privilege it was to hear, Dr. Ron, to hear your dividing that baseline, giving those quite frightening figures of what's happening, and Dr. Harry just helping us to understand the relationships that you have saw and that you helped to build, and Dr. Catherine that's explaining as well how we are needing to increase understanding by doing this science at the community level, where the food system, health systems, animal health, human health, health of the land really come together. And Dr. Collins, thank you. We've got 15 minutes for questions. And I know there's already some questions coming in. So if it's okay with yourselves, could I have a short time of questions, and then we'll come back again just to think about those key messages that you've brought forward. And I know Professor Heather Kubi is online. Many of you know Professor Kubi. She's such an instrumental part of the Scotland-Malawi partnership. Heather, are you able to come online to ask your question, if possible?
I hope so. Do tell me, Liz, if you can hear me.
Very, very clearly. Thank you, Heather.
Okay. Well, thank you to all the presentations from Malawi. They were all great, and what a wonderful job you're doing already. Antimicrobial resistance is obviously a global problem. Malawi is so good at producing national action plans, and whatever help can be provided in the delivery is perhaps where we want to also extend some of the discussion. So I'd like to go back to saying about in the first talk about the surveillance itself. Surveillance is absolutely crucial for future health policy. But beyond the Fleming Fund and fellowships and the tertiary level of expertise, I wonder if there is anything that could be done to build capacity and understanding further down. I know how many labs there are, over 1,000 human labs, many of them very, very small, and really only 1.5% or so able to provide antimicrobial sensitivity testing. Perhaps that engenders a lack of understanding about the AMR issues in a large portion of laboratory personnel. Is there for the number of small laboratories almost acting as a hindrance to capacity building, or can we do anything to improve the educational understanding much further back than at the fellowship level? So that's a long question, perhaps about capacity building, which is central to my interests. Thank you to whoever of the Malawian team would like to respond.
Thank you, Heather. Could I ask one of you to respond? Ron, would you like to?
Oh, sure, yeah.
And then we'll come to Trina, who's in the room.
Thank you. Thank you very much, Heather, for that very loaded question. And I think that where I cannot complete that question, I think I also have given to Dr. Mitambo to address a few other issues. So what can be done to build capacity? And I think the first thing that I would say is that for the Fleming Finance facility, so those 15 facilities, we noticed that for us to get them to par to provide us with standard results, so because we started with facilities that showed the ability to provide us with reliable results, but at the same time, they also needed to be sort of capacity, given the infrastructure, to give us robust information which we can give to WHO, which we can say out loud as wonderful, as well as standardized results. So the first thing that I would say is diagnostic capability, or the investment for setting up these labs to provide us standard results was a lot of money. And I think without the Fleming Fund, sustainability is not something we would have spoken of, because the infrastructure, the reagents that are constantly needed on a daily basis, that is something that is really significant. I think one of the things that we can safely say is important is the data itself. So we can safely say that we have mapped our labs, and we know that, and this is not information that was already available to policymakers. So we have started somewhere by outlining what the problem is and saying that we are underrepresented in the secondaries, so the primary level and secondary level. The tertiary level is because all tertiary level facilities are represented in those priority labs that I spoke of. So we have information now that we have been telling the policymaker that there's something that needs to be done. So what can be done is really using this data to speak to the decision makers. So we are using this data to influence as well other facilities. So we are maximizing utility on these facilities that have been identified as given standard, so that they can act as model capacity development. So we're seeing other facilities that are coming up, even though they don't have the financing, but the councils, local councils, have noticed that this is a problem, and they are trying to finance and improve, and also so that they are able to get those results. So
that's terrific. Thank you so much. What I'll do is I'll maybe take Katrina's question and Barry's question for a bunch of time, and then if that's okay to come back to yourself to speak. Is that okay? Katrina, you were wanting to ask a question. I would love to hear your perspectives as well.
Thanks, Liz, so first of all, thanks for this whole meeting. It's fascinating, and the work that's been done is just inspiring. I have a comment. I'm not hearing the question. So we set up an analysis, and we set up the theory of acute development. There are so many problems, even though we have to use more than 5 antibiotics, but we still have AMR. It's such a massive issue globally, and I just want to comment on how we can learn from each other and what we learn from the work that you're doing about what we're not doing here, and anything that we can do that historically can learn from the fact that we haven't been successful in dealing with AMR over the decades. It's just fascinating to see how this is going to go. My question is a really basic process question, and it's to do with the actual on-the-ground research. Who collected your data with you as the fellows, or did you have other people even in the community or in the hospitals or whatever collecting data? And how did you fund that? And I'm asking this from a position of collecting data myself in maternal health and everything like that, but at a district level in Malawi, and this was just a practical question. Thank you.
Okay, we want to like, give us the microphone over again. Sorry. Fellows, yes, go on. Yeah, I'd like to speak. Thank you.
The data was collected by the fellows, but we had a team, so we had research assistant was the operation. Because we collected the data in about 2 or 3 months, so we had the fellows, but we also had research assistants, and the data was primarily collected from the parts. So the nucleus, the multiplier, and the stormwater parts as the nucleus, and then as the environment we collected the samples from, so from the farmers, from the black coastal chickens, and then the environment.
I think also just quickly after that, I think one of the things that made it really critical and simplified the process was we were part of both ministries. So the Ministry of Health and as well as the Ministry of Agriculture. So for us to go to the ministry, we use structures that are already embedded. So it was much easier to sort of identify farms because there was part of that data was available, and we would use colleagues who also sort of environmental officers, the agricultural or the veterinary officers who are around. And it was more practical and more efficiently done because we were part of the structures. Oh, okay. So we participants were compensated for, I would say, hygiene costs because, for example, they would have to give us people measure some other, so compensated for.
Okay, so we have a question from Barry Hassan, who's online. Hassan, sorry, Barry. Are you able to come on and ask? I'm conscious of our time, and it would be great to have your question and then to get a little more perspective from the panel here. But Barry, if you're able to ask a quick question.
Thank you, Liz, and thank you to all the speakers for their insightful look. And I would just echo what our chair, Heather, said. It's great to see Malawi engaging in antibiotic resistant surveillance and monitoring, because you will drive policy for the nation on that. I think actually the third speaker answered my question after I'd already added it to the chat, that you are seeing that direct link that we've seen elsewhere in the world of the judicious use of antibiotics in the animal world and the agricultural world actually having a direct effect on increasing drug resistance in humans. Could I be cheeky and ask a little supplementary of the panel? Because I'm really interested as an emergency medicine clinician who's helped support the development of emergency medicine in Malawi. I know that the clinics and hospitals have limited supplies of drugs from times and often use not the first line antibiotic of choice, sometimes the second and sometimes to the third. Are you finding in your work that that's leading to increased risk of antimicrobial resistance?
There's one if you like.
Thank you, thank you for that question. Some of the fellows that I also work in the pharmaceutical division, the Ministry of Health. And I think one of the reasons looking at our baseline data, we're using solid antibiotics because we also sometimes have stock outs, which limits the availability. So this is one of the areas which is seen to be contributing to resistance. So just to link with Heather's question, I think what the baseline data is showing us, as we're reviewing our national action plan, we're really understanding the context that we have as Malawi and tailoring our national action plan to suit the challenges within our context to best tackle the problem that Malawi is facing with regards to AMR. So in our revised national action plan, in optimizing use, ensuring access to antibiotics is one of the key elements, because we can't have split it if we don't have the appropriate options to select from. So that's one of the key things that we're looking at. Thank you.
And just to add a big one, in terms of us for advocating for availability of products in the hospitals, what we've done as a antimicrobial stewardship committee, the chairperson of that stewardship committee is a permanent secretary, the secretary for it, was the top one controlling officer. So we try as much as possible so that he should be a champion to be telling all partners that we need.
Thank you. I see we have two quick questions in the room. If that's okay, I'll take two together and then we'll come back to you in the last 5 minutes. So Tracy. Oh, yes, please.
I have
Yeah.
got a really loud voice, but I so I was really pleased as a question of environmental health. I was really pleased because I was feeling my question, where is environmental health in all of this? And we've been part of a research study done, which I'm sure you'll read of for all of you as well, which has really shown the slightly stressful wide dispersal of antimicrobial resistance in the wider environment. So again, I'm thinking about the National Action Plan. My question is more about how do we move from that idea of surveillance to actually making the change? So not just around antimicrobial stewardship, but also embedding those water sanitation hygiene elements as well that we need to do to reduce the transmission within the community of the AMR that's already there.
Great, and I'll get you to just ask your question as well, and then we'll come back to you.
More of a prominent in conflicts and global health, but also with a background in cell biology and research. And bacteria are very good at sharing genetic information from cell to cell without cell division. And they do that in cassettes with a number of genes. One of the things that's been recently noticed is that they can do that without necessarily getting exposure to antibiotics. And secondly, that there are other chemicals that seem to be promoting that sharing of antibiotic resistance. For example, ibuprofen, which is used as pain relief, can increase the sharing of this genetic information that leads to resistance to antibiotics. So given that we have a international network that's collecting data, that's looking at surveillance, is it worth also collecting some of the information about other drugs, other chemicals that are being used alongside, and where you see antibiotic resistance being manifest?
Okay. So in the last few minutes, are you able to give a couple of minutes more of a quick comment? Yeah, and they were, these are questions that would probably require an hour, but comments. Yeah.
Yes, that's interesting about the information. Yes, what we are trying to actually the national action plan, we are trying to prioritize areas of interest. And what we've been pushing for us for Malawi, just we want to have a document on the table, on the table, but we want to make sure that. So one of the strategies we want to follow, we are really involving as a ministry, there's a section on environmental health for officers there, but we've got also another ministry, environmental affairs, and the Malawi environmental regulatory authority. So what we want to do is to we have been pushing and trying to reach out to their ministry so that we should the approach of one day, we should also make sure that we have got people from the community. We understand that they've got different strategies, and some of the strategies they have, it's just a matter of us finding resources and finding them. And yeah, because there's also this talking between the Ministry of Health and the environmental health, we also notice that there are some gaps in terms of issues of antimicrobial resistance. So as a strategy, we are trying to engage them as much as possible, and we are trying to make sure that they're on the technical working group so that they should also be able to interact and also be able to fund and develop harmonized work plans with them.
Brilliant. It's really interesting.
Hi.
Okay. No, just think, we haven't heard from yourself. I don't know whether you want to say anything just very quickly.
Okay.
Mike, sorry.
Yeah, as the fellows, and a lot of things that we met, mostly about this. And I come from an background. There are a lot of things, areas where we are lagging behind. The fellowship program, at least, we're always on our toes. Surveillance, our colleagues on the human side have assistance a lot. And I'm sure, there'll be much, doing our sector in the next 3 to 4 years to come. It will not be the same as the economy. And the other thing is, I just wanted to comment about, the way the question will be how we, created data from, when we're collecting that, that information, we had also to train our, surveillance systems. Because we know that, we're not that far, the situation of skills. And also, the knowledge that those surveillance systems so we have to train them, data collection. And the other thing is, we also have to retest. So that also help, us to gather quality, information from the field. Thanks very much.
Thank you. Thank you. We've come to the end just about. Before I hand over to Stuart, can I just say how significant this is? How you've talked about you're shaping national policy, and we have to learn together here, how do we shape national policy? The whole session was around safety, from you, Sarah, talking about the safety of strategic use of equipment and the sharing of it. We talked about surveillance, about stewardship, about using science well, using it properly, about speaking out with the evidence and enabling others to speak, and about sustainability and the standards that matter. And you talked about staying together and learning through sharing. So I want to say thank you from each one of us here. Thank you from the forum, this opportunity to share and to learn together. And maybe Jill, I'll ask you, because you are one of the AMR experts here in the UK and in Europe. Have you a comment here that you want to make around what we're seeing and doing?
Yes, without a microphone.
It's microphone.
Yeah, so I mean, a comment. I don't want to. Thank you. I don't want to reiterate what has been said. So it's really fantastic. And but one thing I had a comment actually on this on the diagnostics because Ron said and Heather asked about the implementation and barriers for capacity building probably, and this reflects to you said points also about you don't just want to have a document. It's all about implementation of interventions. It's all about the looking at assessing the impact and ensuring that there is and understanding what the barriers are for implementation. I'm a diagnostics at my heart. You may know about the Nobel Prize. It's an $8 billion award, which is given out to the government for someone who develops a rapid diagnostic test to preserve antibiotics for future generations. Essentially, it's a point of care test. That's for primary care. So implemented in primary care, probably for primary care. My postulation is it will be for primary care. And that's because this is where in the human sector most of the antibiotics are used. Why is this test done? Because, or this award, why has it been launched in 2018? Because there's a global market failure. Don't have the diagnostics. So Malawi is not alone with this model. So no one can do antibiotic-resistant testing in primary care. We don't have that. So we cannot make an informed decision based on susceptibility in primary care to give an antibiotic. If you think about this, this is horrific. So we need to do something about this. And we may have technologies which are pointed to what is once the long-term price has finished and someone has got the award and here that would be interesting technologies coming out. But then we need to implement it. It's all about the implementation and ensuring, as I said, making sure those implementations work. And partnerships like these will help to do that. And so I'm looking really forward to continue working with you, continue working or working in the second phase to expand more. Thank you so much.
Thank you. Thank you to have the expert from Malawi in the room. This is tremendous for us, and this is what partnership is. Over to you, Stuart.
For fascinating presentations, and really just to, on behalf of the Scotland Malawi Partnership, to thank Professor Listrand very much for chairing today. It's so very excellent. Video of today, the presentations will go online the next 48 hours or so. And thanks to all of our brilliant speakers here today, for everybody who's come to appear in 3D in person in the room with us, and those taking part online from Malawi, different parts of Scotland elsewhere. Thanks to the Scotland Malawi Partnership team, to Chaz for leading with this event, Dorothy, to Tasha, Henry, Katia, Ellie, and to Alan for paying the bills, and to the Scottish Government for giving us the money in the first place to do what we do. Next Tuesday, the 27th, we have an event on forestry. The screens is showing when we'll hear from Dr. Henry Katsuma on some of the issues around tree planting in Malawi. We'll also hear from Rotary International about their really ambitious plan to plant 5 billion trees globally, including for pilot projects in Malawi. And then on the 13th of July will be the Scotland launch of the UK Malawi Chamber of Commerce here in Edinburgh City Chambers. You're very welcome to all and any of the events. Most of them are a very warm welcome. But for now, thanks very much, and please feel welcome to stay and chat and enjoy any Zoom coffee that's fine. Thanks very much.